for being here today. Our cell series today is on lung cancer screening and using Nevada's lung screening toolkit. We're very honored to have Dr. Jamie Stutz join us. Dr. Stutz is professor of medical oncology at the University of Colorado School of Medicine and scientific director of behavioral oncology. He serves as the co-leader for the Cancer Prevention and Control Program and co-director of the Population Health Shared Resource at the University of Colorado Cancer Center. Among these many hats and others he wears, he is the principal investigator for the Kentucky Leads Collaborative, and he previously served on the Institute of Medicine National Cancer Policy Forum addressing implementation of lung cancer screening. He is a fellow of the Society of Behavioral Medicine, a member of the Scientific Leadership Board for the Go-To Foundation for Lung Cancer, and he recently joined the National Comprehensive Cancer Network's Lung Cancer Screening and Smoking Cessation Guideline Panels. Dr. Stutz serves as a member of the Steering Committee for the American Cancer Society National Lung Cancer Roundtable and chairs the Survivorship, Stigma, and Nihilism Task Group. Dr. Stutz, anything that I missed that you'd like to include in your introduction?
Not at all. Just happy to be here and excited to talk about this topic and the opportunity for lung cancer screening in Nevada.
Well, we have a few housekeeping issues. If you'd advance the slide, please. Thank you. So for all of our participants, if you have a question, please locate the Q&A box and type them there. We will address questions throughout the session and review all remaining questions at the end. The recorded webinar and slides will be posted to the youtube.com Nevada Cancer Coalition channel at the link on this slide. If you experience connectivity issues, please log back in and we'll continue where we left off. I'm very honored to hand it over to Dr. Stutz now. Thank you.
Thanks, Lily. I really appreciate the invitation to try and use some of the work we did in Kentucky and the work we're doing now in Colorado to see if there are ways to leverage this work and accelerate the lung cancer screening opportunity in Nevada. And I think, with some of the data that we've talked about with the coalition leadership, as well as some of the things I'll highlight today, we really want to emphasize not the challenge of this, but rather the opportunity. And I think that thinking of this as an opportunity can really help leverage some of that momentum and work to really make this something that brings better health outcomes to the people of Nevada. So I want to mention just a couple of conflicts. I do some consulting on various initiatives to expand access and implementation of lung cancer screening. We have some really strong industry partners, and I'm proud of these relationships that some of our pharmaceutical company partners have leveraged their resources to really bring additional opportunities, including J&J, work with Genentech. I think Lily mentioned the partnership with GoTo, but also some of the funding that I've had from the NCI, American Cancer Society, the Colorado Department of Public Health and Environment, PCORI, and the Bristol Myers Squibb Foundation. Oftentimes when we talk about lung cancer, we start off discussions by focusing on the burden. And while we still can do that, I prefer to talk about, started out with a stance of optimism and hope. Because we have reason to be optimistic. We have reason to be hopeful. Over the past 10 to 15 years, there's been an absolute transformation in what is possible in terms of lung cancer. And this is highlighted in the last couple of years in the American Cancer Society's Facts and Figures reports. We're seeing incidence trends in lung cancer that are declining year after year and accelerating in some cases. is the mortality trends are really accelerating. From 3% declines in lung cancer mortality in previous years to 5 and 4% per year, respectively, during the most recent period of time that they examined. And from the time of diagnosis forward, we're seeing people live longer and live better and have genuine survivorship periods of time. And these are things that implementing lung cancer screening more effectively can do for Nevada, can do for Colorado, and can do for our nation and even the world. And so this is the motivation. We want to accelerate these trends more rapidly. I want to transition to talking about the lung cancer burden in Nevada, and this is something that I've done to educate myself, and maybe these are all very familiar to you, but I think they're worth mentioning to get us going. We're actually seeing the number of lung cancers in Nevada increase, and that is not corrected for the population size. So as Nevada grows, you would expect more lung cancer diagnoses unless we do a better job. And then finally, lung cancer mortality. After some period of decline between 2015 and 2021, they're actually seeing an uptick in Nevada in terms of lung cancer deaths. And once again, this is not corrected for population size. And so as your population continues to grow, you will see more. Now, these next data are corrected for population size. They are actually rates of lung cancer incidence. And when you correct it for population growth and trends in aging, you can see that there are declines in lung cancer incidence rates. But I want to make 2 points with this. One, these rates are not declining as fast as the national average. The other point about this is you can see that the male rate of incidence is declining faster and now has caught up to the lung cancer incidence rate in women, and that is not very common across the country. That indicates that Nevada women are, experiencing an elevated risk of lung cancer that's not declining as fast. And you can see that same trend in terms of mortality, that these are subtle differences, but nonetheless they are noteworthy differences, that the benefit in terms of reducing lung cancer mortality is not yet as robust among women in Nevada as it is in among men in Nevada. Now, I want to do just a little bit of comparison with regard to the lung cancer epidemiology and sort of setting the table for this discussion. And does the same thing. I've tried to use some Nevada numbers. I actually looked at, or not numbers, but colors. I learned that the Nevada colors are silver and blue from the Nevada State website. So I've tried to incorporate those. And you can see here that the incidence rate in men in Nevada is significantly lower than the national average, but the rate among women is very similar. Now, my former home state of Kentucky really takes this off the charts in terms of the rates are 1.5 times the national average and more than twice the average among men in Kentucky, but not quite twice the rate in Nevada for women. And the same here with the mortality rate, still devastatingly high among men in Kentucky, as well as much higher than the national average among women in Kentucky. And you can see here that the smoking rate exceeds the national average in Nevada and whoppingly exceeds the national average in Kentucky. And now I don't say these to really lean into the problem, but these are the kinds of things that will change with implementation of high quality lung cancer screening in the state. While the thing that will change the most would be eventually the mortality. But if you do lung cancer screening really well in various settings, you can actually see an impact on incidence because you're actually working with individuals to cut their smoking and using lung cancer screening as a platform to help individuals quit smoking, and for those individuals who are eligible for screening. Now, the real bolus of our talk, or the emphasis of our discussion today, is leveraging the data from the National Lung Screening Trial published in 2001, where you can see that individuals who were randomly assigned to receive a low-dose CT versus those who received a chest radiograph lived significantly longer than each other, and that this really was the first trial to show the definitively that low dose CT could not only detect lung cancer earlier, but we could translate those results into reduced lung cancer mortality. Some years later, it was followed by a report from the Nelson trial in 2020 that actually showed a very similar effect, screening benefits associated with the low dose CT versus nothing. So the control group in this situation did not have any screening whatsoever, and yet you still see this mortality reduction in lung cancer specific mortality. Now, the one thing that I don't highlight in these slides that is particularly relevant to Nevada is the fact that both of these studies showed that participation in lung cancer screening was slightly more beneficial for women than it was for men. And so, taking the context of that Nevada women are not yet experiencing some of these benefits, it really stands to argue that implementing lung cancer screening in Nevada could have a disproportionate benefit for individual women who are eligible in Nevada. But you probably know as well as I do that this is not really happening. In Kentucky, we are proud of being the #2 state in the country in terms of implementing lung cancer screening, using the most recent data from the American College of Radiology Lung Cancer Screening Registry. We see that 10.5% of Kentuckians have had a lung cancer screening test among those who are eligible. Nationally, that the average is 4.5% of Americans who are eligible for lung cancer screening who have had a scan. And unfortunately, Nevada is in the lower tier. We're around 1.4% and ranked number 47th. Now, this is based on the new and expanded eligibility criteria. And just want to let you know I'm not throwing stones, because Colorado is just a few notches above you here, and really in the same realm of a pretty below average tier of implementing lung cancer screening. And that's sort of a theme of a bit of the West that really hasn't harnessed this, and there are a number of potential reasons for that. I want to highlight this as also another signal of the potential, because it wasn't magic that Kentucky really is starting to leverage the lung cancer screening platform more effectively. And it was through conscious efforts. Sorry about that slide tweak. We can see here that when you put out on a graph the states that have the highest rates of lung cancer screening, and then the actual here, and then on this axis, the actual burden of lung cancer mortality, you can see that Kentucky is pretty much the only state with a substantial tobacco burden that's leveraging the lung cancer screening opportunity even remotely to its benefit. These other states of Massachusetts, Vermont, and New Hampshire are doing better in terms of implementing lung cancer screening, but they don't have the same burden. You can see some of the states with the highest lung cancer burdens: West Virginia, Arkansas, Mississippi, Tennessee, Alabama, Oklahoma, Louisiana, Indiana, Missouri. These states are really not doing a very good job with lung cancer screening. Now, thankfully, Nevada is much lower on the lung cancer burden level, but it's also hovering very close to the bottom in terms of implementing lung cancer screening per state. So it does create some more opportunities. Now, I continue to
Dr.
use.
Fitz,
Yes,
I just have a question really quick. I'm gonna
yeah,
unmute Carla so she can ask her question.
absolutely. Thank you for the question.
Carla, do you want to unmute and ask your question? looks like she's not unmuted, but if she wants to drop that in, I'll bring up the question again.
And thanks for doing that, because I forgot to mention at the very beginning, if anyone has any questions that they want to chime in, or disagreements with any of my opinions and expressions, please don't hesitate. Happy to have a good discussion. I continue to believe that lung cancer screening is the most substantial missed opportunity to reduce cancer mortality. Oops, I got a reference to my talk I gave in Nebraska a couple weeks ago, but among people, and not just in Nevada, but throughout the U.S., and not just lung cancer mortality, but overall cancer mortality. And if you go back to that report from the American Cancer Society that shows that the declines in overall cancer mortality, that's almost all us. That's almost all change in the reduction in lung cancer. There have been minor changes in other areas, minor increases in other areas, but the overall scope, it's almost entirely explained by improvements in outcomes in lung cancer. And we want to harness that hope and that optimism and that potential to keep accelerating those benefits. And one of those pieces is really leveraging lung cancer screening to its greatest potential. And so we have this opportunity for a true paradigm shift with these two data sources, with the favorable policies that we have from the Preventive Services Task Force and the Center for Medicare and Medicaid Services. But we're in a transition period to really leverage this opportunity, and that challenge is implementation. And if we're going to turn that challenge into opportunity, we have to understand that not only is this a new service, but we're engaging new people, and not just new people in terms of the candidates who are eligible, but also new people who are conducting screening themselves. Many of these folks come from a pulmonary or radiology background that don't have as much experience with screening. Screening is an optional thing in our healthcare system, and not understanding that people make choices about screening, it's not mandatory, that we have to understand that as part of who they are and what they're coming to. And this process is more complicated than other screenings, because it's not like the population-based screening that we have for breast, cervical, and colorectal cancer. This is targeted screening that's based on a risk factor, more informative than just someone's age. We actually can look at someone's tobacco history and understand the risk-benefit ratio of participating in screening and the eligibility for screening much more effectively. And that's a good thing, that we don't have to screen everyone to benefit those people at highest risk. So what has that challenge been? Well, it's been pretty significant. We've seen challenges with implementing shared decision making. We've seen challenges with screening the right people, and that initially when we started, that many of the scans that were being done outside the eligibility criteria, whether someone was at lower risk or actually having competing demands on their mortality. There's data showing that the harms are higher than we saw in the NLST, and we have to be conscious about those and balancing those benefits and harms, and doing screening in a quality way, not just doing screening, but do it in a way that actually increases the likelihood that people will benefit. Now, having worked in the state of Kentucky for a very long time, I've adapted the analogy of the very beautiful new 2020 Corvette, and I equate that with low-dose CT. Now, the reason I chose the Corvette is because it's actually built in Bowling Green, Kentucky, at the factory there. And I think there's a lot of parallels here. That a low-dose CT is a beautiful new machine that's ready to go. We have lots of CT scanners that can do lung cancer screening tests across the country. We have the data and the policy, which serve as the fuel to power this beautiful new machine that is ready to go. But we need partners in primary care. The partners in primary care are the ignition switch that make this machine go. Without their collaboration and partnership and engagement around lung cancer screening, none of this is going to happen. This tool is going to be a relic, something that's, looks great, but it's useless. We also have a crew of people that support the use of this tool, and that's the lung cancer screening program staff. The navigators serve as the sort of the manager and the pit crew, but they're also fairly new to their game and figuring out how best to serve this community. What we often don't realize is that we're not in control of this. The person who's at the center of the lung cancer screening process, or who needs to be at the center, is actually the candidate and the participant. They are driving this machine. It is not the navigator that drives this machine. It's not the radiologist. It's not the CT surgeon or anybody else. We have to respect the autonomy of the driver of this individual, and that because the benefits accrue to them for participating, but yet they are experienced because lung cancer screening is new. We have to do everything to help them provide the tools and the training and the supports to make this system run well. And finally, we know that the lung cancer screening experience is a bumpy new road course that people have not driven before. We have not been doing this for long enough to be able to smooth out many of those rough patches. We know that we detect a higher rate of false positives that we have to sort through, and a higher rate of incidental findings that we have to help people sort through. And therefore the course is bumpy. But if we can partner with and provide the support through the lung cancer screening program staff, we can make this tool fast, effective, and in a way that can really churn out the results for our community. I focus a lot so far on initiating or launching screening or getting it going. But in reality, the only way to benefit a population from lung cancer screening is to combine a commitment to not only reaching individuals and creating opportunities for them to participate in lung cancer screening, but supporting them through the entire trajectory of participation. Whether someone has some incidental findings that need to be followed up, whether they have a frank malignancy that we have to get tracked down, or just someone who has lung rads 1s and 2s that are going to be scheduled for annual. We have to find ways to support this community, understanding who they are and what systems they need in place in order to continue, because this is where things change. Lung cancer incidence and mortality do not change with a single scan. They change over time when someone has participated in a second, in a third, in a fourth annual scan. That is where we are really able to benefit and change both individual and population health outcomes from lung cancer. So why is this process going so slowly? Well, translation takes time, but that's not a satisfactory answer. Many times I think we've fallen prey to the field of dreams fallacy. If you build a screening program, they will come. But that fundamentally fails to understand the community that we're trying to serve. And I'll talk a little bit more about in that a little bit. And by the way, that is the Field of Dreams in Dyersville, Iowa. Oftentimes we have not recognized that we have to build a community of awareness and engagement, that it has to be normative in our society that lung cancer screening is just another cancer screening that people consider doing if they're eligible. That we need to build systems around our organizations, around our healthcare systems, helping raise awareness among our primary care clinicians, help them build it into their workflows to create this as normal healthcare. It's not special, it's normal. It's what we all need to be doing. And we also need to reach and engage this community of screening eligible individuals, as well as their family and peer groups, to also set up lung cancer screening as normative and support it in our society. But we fall short because we often use fear as a strategy to engage people with lung cancer screening, and it's exactly the wrong way to do it. We've been peddling fear and stigma for decades with regard to smoking. Our community of individuals who smoke are tired of it. They're exhausted by that message. We've taught them not to pay attention to what we say around that. We need to be much different in our approach. We need to work on empathy and compassion and support and giving them the sense that they can trust us with their healthcare, that we act in trustworthy ways, and that persuasion is not a trustworthy way and of approaching this community of individuals. And I'll highlight that more in a little bit. We also want to understand this, as I've kind of highlighted, from a socio-ecological perspective, trying to take in everything at the community level, both our clinical community infrastructure, but also our public infrastructure, and helping understand. And a little bit more, I'm just introducing these ideas, but also among our lung cancer screening program team to create a culture of trustworthiness and value and support and empathy for this community of individuals. And finally, we have to show that to the candidates and participants in our programs, that they made a wise choice to start screening, and we can help them throughout the screening process and keep them involved as participants in our programs. And the way we've done that is thinking across all these different entities and supporting in different ways, but it comes down to two fundamental pieces of the equation. And those are person-centered actions and extensive community engagement. These are the what I call the people part of lung cancer screening. We are by and large getting the technology and the technical and the radiology parts of lung cancer screening correct. We're not doing a great job of the people part. And I'll be focusing on a little bit more on that and how we've leveraged the people part to really make the most so far of the lung cancer screening opportunity in Kentucky and some other places. So on a community level, if you were to go out in the street in Nevada or Reno or other places and ask the next 100 individuals, what is a mammogram and who is eligible for it? Virtually every adult is going to tell you that it is a tool to detect breast cancer and it's for women. And yet 50% of those folks aren't going to be eligible because they're going to be men. Now, if we were to go out on the street the next day and ask the next 100 people what is a low dose CT and why you do it, virtually no one is going to be able to tell you why you would do a low dose CT, nor who is eligible or why you would be doing it. That is the social level of community awareness and engagement that is a barrier to us right now, because there's no public discussion of lung cancer screening going on. Every woman talks with her friends, virtually every woman that participates in mammography will openly share that it's mammogram day, I got to go get squished, or other kinds of discussions around that. It's just not part of our public dialogue to talk about lung cancer screening, and yet it needs to be. So one of the things that we did in Kentucky, we called it the Great Kentucky Lung Cancer Screening Roadshow. That's not actually what we called it. We only called it amongst us. But what we did is we held meetings across the state, and it was a bi-directional sharing with community partners about the lung cancer screening opportunity in 14 different locations throughout the state of Kentucky, where we invited clinicians and advocates and community members to discuss lung cancer screening. Now, we started this back in 2013 and 2014, bringing people together to share with a moderator who was a local community member, that a primary care clinician would present. We had I was the lung cancer screening expert, and we also had an epidemiologist who would present, and then there'd be a public discussion about this, and trying to create awareness and a social norm and encourage people to start talking about lung cancer screening in their healthcare systems. We also did extensive clinician engagement efforts. Our colleagues at the University of Louisville and the Kentucky Cancer Program, as part of the Kentucky Leads Collaborative, developed an academic detailing platform where we would go out to primary clinician offices and clinics and try to support lung cancer screening. We also did some continuing education training and had an online training course that some folks have may seen, and we did other national and local webinars. And I think this is many ways the secret sauce of what we did. we were able to reach almost 3,000 primary care clinicians and their staff with messages about lung cancer screening and normalizing lung cancer screening. We communicated the evidence and about the screening programs in their communities to almost 1,500 primary care clinicians in terms of MDs, NPs, and physician's assistants. And we also educated their staff. In doing so, we're establishing a clinical culture of supporting lung cancer screening, but also a societal culture of normative lung cancer screening, that there should be no shame or fear or nihilism associated with lung cancer. And we really have to leverage this opportunity. So it's a significant amount of engagement with primary care clinicians. Now, moving on to the lung cancer screening program team, also within the Kentucky Leads Collaborative, we wanted to develop, based on evidence, a quality system that helps evaluate the programs to make sure that we're not just getting the techniques of lung cancer screening right, but we're getting the people part right as well, and to provide tools and supports and trainings to help lung cancer screening programs integrate that person-centeredness and to recognize their responsibility and being community engaged and doing outreach to clinicians and to the community. And we wanted the system to be evaluative and to give feedback and opportunities for support. And so we developed the QUILS system, which is the quality implementation of lung cancer screening. And it involves an index based on program data as well as policies and procedures, and that we would evaluate, and then we would give feedback to the screening programs to say, here are the strengths of what you're doing, here are the opportunities you have to change your program operations and improve those. But when we didn't stop there, we said, here are some resources to help, train your staff to do this differently, to help integrate the resources about how to measure tobacco use more effectively, or how to talk about tobacco treatment, or how to integrate other lung cancer risk reduction strategies in there as well. And then we would go back and reevaluate these programs to see if they'd actually made improvements in their operations and their delivery of lung cancer screening to achieve that quality. And so here are some of the parameters that we were interested in. I mentioned that we were interested in the technical domains of lung cancer screening with regard to who folks are screening, how the radiology is being done, and that folks are using as much of an interdisciplinary team approach as possible. But we were also all interested in the people domains. How do we use lung cancer screening as a true lung cancer control program? How can we integrate evidence-based tobacco treatment, discuss secondhand smoke exposure, discuss radon prevention activities in order to really leverage this platform? Because we're not interested in these people to deliver them lung cancer screening. Our interest in this community of individuals is to reduce the chance that they get or die of lung cancer. And there are multiple ways to do that. And when they take the chance in trusting us to do lung cancer screening with them, we have an opportunity to talk about these in evidence-based, compassionate, and understanding ways. But if they say, Jamie, I'm really not interested in quitting smoking at this time, I say, Bob, that's fine. We're here to support you. And if it's not the time, we still want you to engage our lung cancer screening program, and we can talk about that at another time. Because the most important thing is engagement here, that they keep coming back, that we build their support and act in trustworthy ways. And one way to doing that is to sharing the decision with them. We've made this such an unfortunate choice to treat shared decision making as a barrier to lung cancer screening. It is an asset. It is a resource, and we've shown that individuals who participate in shared decision making and have that documented are more likely to keep coming back. Shared decision making brings us value and respects the individual who participates in lung cancer screening. And then we need robust engagement and retention efforts to sustain this communication over time. The other thing that's important is to be doing community outreach, to using responsible and best practice marketing tools and outreach efforts, not just for our clinical partners to keep their referral streams robust, but also to normalizing lung cancer screening in our community, as I've highlighted. We implemented this system at 10 different sites across Kentucky in very different settings, from academic medical centers at the University of Kentucky to regional medical centers at Appalachian Regional Healthcare and Hazard and Pikeville Medical Center, in Owensboro Health in Owensboro, and all the way out in Paducah, Kentucky. So in Kentucky, we talk about from Paducah to Pikeville as covering the whole waterfront in a state that doesn't have a waterfront. But what were the outcomes? We found that at baseline, folks were receiving about 2/3 of the quality points available in our system, but over time, over a period of 18 months, they were able to get up to 80% on average of the quality points, with still opportunities to continue to improve. Because our quill system doesn't focus on a minimum set of quality standards, it focuses on optimization, at being the best, optimizing the people and technology experience. Then finally, I want to talk about the lung cancer screening candidates and participants. And I use those terms specifically because we think of people who are eligible for lung cancer screening as candidates for our program. And we do not tend to refer to them as patients once they participate. They are participants. And that we try to use that to engender a sense of commitment, the understanding that this is their choice and that we can do things yet to support them and keep them engaged to be sustaining participants in our programs. That but that fundamentally, to get the people part right of lung cancer screening has to begin with a fundamental understanding of the community that who are eligible and the community that we're trying to serve. And these folks face a significant degree of social stigma and self-blame related to their smoking history, regardless of whether they currently smoke or formerly smoked. So they're coming to us in some ways expecting us not to respect them. Fundamental problem. If we assume that they respect us, we've made a misstep. They also tend to be more fatalistic because smoking experiences tends to accumulate in families, so therefore they have experiences with lung cancer diagnosis oftentimes, and historically, lung cancer outcomes have not been as good as they are today. And even our society still thinks that they're horrible. And so there's a certain amount of fatalism that lung cancer screening might not be good for them or might not help. There also tend to be lower resourced individuals who are skeptical about some of our methods and practices and messages around lung cancer screening. Sometimes we put up big pictures of CT scanners and expect that a lower resource community is going to think that that's fancy. Well, actually, how they interpret that picture is expensive. Now, we all know because we're involved in lung cancer screening that lung cancer screening at least the scans themselves are free based on the Affordable Care Act and Medicare coverage and even Medicaid coverage in most states. But if we get the message wrong, we actually tie into that skepticism. This is also related a disengaged community because of the stigma and fatalism and the skepticism. This is not a community that typically, on average, engages in is healthcare information seeking. So we have to help. We have to find them. They're also dispersed, and you probably know this as well as anyone, given the large open spaces in Nevada, the frontier belief system, and in rural belief system that we have a disproportionate burden of lung cancer screening eligibility in those communities, and so we have to find ways to build engagement through transportation programs and supporting them in ways. Now, we don't want to use this characterization to be stereotypical, but in order to achieve that person-centeredness, we really have to engage these principles and find ways to deliver empathy and compassion. My colleague, Dr. Lisa Carter Harris, now Carter Bawa, has shown that people make these comments with regard to lung cancer screening and feeling stigmatized and being made to feel stupid because of their smoking history, whether they currently smoke or formerly smoked. But also there's a lot of distrust that sometimes the way we message about our lung cancer screening makes it sound like we're out there to make money. We're out there to deliver a scam or execute a scam and just try to get more people diagnosed with lung cancer so we can deliver them therapy and make a whole bunch of money and they're going to die anyway. Well, that kind of distrust and fatalism really is pervasive in our community. So we have to be cautious about how we communicate with this community and the message that we send. And why are these things so toxic to what we're trying to do? Well, I'll ask you to think. When was the last time that you did something when you anticipated that people would treat you poorly for doing it? Now, we'll put that on top of a belief that when was the last time that you continued doing that same thing when you anticipated that it really wouldn't work that well? Now, I jokingly refer to parenting adolescents as a pretty good example of this and giving them advice and, it's not going to work and they're going to treat you poorly, they're going to get mad at you. But in the lung cancer screening context, this equates with a belief in that stigma and nihilism and fatalism that pervade the community that we're trying to reach with this healthcare delivery opportunity. And that we have found in our own research that you can actually bring value through shared decision making and respect someone and address these kinds of things by being trustworthy, to use person first language, be aware of your own biases, to normalize lung cancer screening as a preventive health service, and invite people to this, and to invite people to be engaged, not tell them what to do. And that brings up the discussion of persuasion. So oftentimes in public health messaging around lung cancer screening, we've adopted the tobacco control playbook, unfortunately, that we tell them what to do. We pressure them. We paternalistically, condescendingly tell them that if they don't do this, they're going to die. That is inherent in some of our messages and some of our imagery that we use around this. And that is particularly problematic for individuals who experience their healthcare as being stigmatized, fatalistic, skeptical, and disengaged. But instead of thinking about persuasion and taking it on our responsibility to make them or get them to do something, if we try to engage them with the opportunity, we share information, we provide options, we respect their autonomy to make a choice that's right for them. We build trust, we build a relationship with our messages, with our imagery, in order to put this as an option and is more likely to translate into not only them initiating screening, but them sustaining and adhering to the screening algorithm where they're really most likely to benefit. We've also developed what we call the best practices for lung cancer screening messaging that really focus on conveying accurate information, that the call to action is engagement with a healthcare clinician. It's not get screened or do this. It's we encourage them to talk with their primary care clinician or their healthcare trusted resource about this. And we seek a balanced presentation of harms. We're not benefits and harms. We're not trying to persuade them by only presenting one side of the equation. And then we really have to avoid fear-based appeals that engender and that cause stigma and engender distrust. Now, some of these principles have been embedded in our work with the International Association for the Study of Lung Cancer and the Language Guide to help people use person first language, not to blame individuals, and to work toward ending stigma and infusing equity. And we've used some of these principles to guide our work on the lung cancer stigma communications assessment tool, which is forthcoming. We used to call it the lung cancer stigma biopsy because it would take content that's been developed around lung cancer and try to identify stigmatizing language and to change it. And so what we did then is we adapted this to consider language, imagery, and context of our communications. And we provide some instructions on how to use this. But basically, you go through a language audit. You can take something you've developed and say, what language is in here that could be stigmatizing? And then we provide alternatives to that if you find examples that could be changed. The same way with imagery, and an imagery alternative guide to think about why. In my world, I've only seen a single lung cancer screening advertisement that used any kind of smoking related imagery effectively. And that's the work by Genentech that really leveraged um, the nostalgia of the 60s and 70s when smoking was common and more normative. And what they were saying is like, if this was you at that time, you might want to consider lung cancer screening now. it may be relevant for you. It's not in a condescending way, but vast majority of times it's being used in a very stigmatizing way. And I can go into examples, even widely publicized uh, national leading organizations that use this kind of stigmatizing language and imagery. And finally, we have to consider the context of which we're using these tools. And sometimes they're just not right for the appropriate context. And so finally, I think I want to kind of work toward wrapping up and trying to leave a little bit of time for discussion. But one of the other lenses that we have to do, we're just not implementing lung cancer screening. We're implementing lung cancer screening to a group of individuals that needs to be approached with an equity lens. That we really do need to work toward infusing equity into everything that we do around lung cancer screening, and to target outreach and engagement opportunities to collaborate with specific community organizations and representatives, to reach out to clinicians who serve underserved communities, working with our federally qualified health centers and other service centers where a higher percentage of individuals are eligible for lung cancer screening or receive their care. And if we do this well, we know we already have lung cancer disparities outcomes, but if we don't do this well, those curves are going to become bigger. They're going to become broader. We're going to see more disparities in lung cancer outcomes suffered by those individuals who are disenfranchised and at the fringes of our society. But if we adopt a perspective of engaging diverse communities, using diverse methods and diverse levels of intervention, we have a chance to mitigate and perhaps eliminate some of those equity issues that we see in other cancer screening programs and cancer care. But thanks to our federal studies and our knowledge of tobacco, we know where these communities of need exist, and they exist starting in our rural and frontier communities. We know that our veterans have a higher burden of smoking and lung cancer. The African American community, the LGBTQ community has some of the highest rates of adult smoking and eligibility for lung cancer screening, right alongside individuals diagnosed with mental illnesses or have varying abilities and disabilities. The American Indian and Native American population, and I'm not talking about spiritual use of tobacco, but I'm talking about, smoking cigarettes, and which makes you eligible for lung cancer screening as well as risk. The Hispanic community and some of our urban centers and populations that experience barriers to care. But when you put all this package of things together, it can work. So I've already shared that, Kentucky has reached a state where we're number two. And this is, like I said, this is corrected. It's not just because Kentucky has a high degree of smoking and lots of eligible individuals. This is per eligible individual at this time. But this next slide is perhaps the one I'm most proud of in my entire career. And that's, you can see that the first signal that we see beyond implementation of lung cancer screening is rates of late stage lung cancer diagnosis. And you can see in Kentucky that we're seeing a significant decline between 2000, or a slow decline from 2009 to 2014, but then an accelerated decline from when we started working to implement lung cancer screening in 2014 in Kentucky all the way through 2019. Now, we don't have any more data because of data lags, but we hope and we believe that this number is actually accelerating 2 times faster than the rate in the United States. And in Appalachian, Kentucky, which is literally an epicenter of lung cancer in the entire world, that rate is 19%, which is 3 times faster decline in lung cancer deaths, or lung cancer late stage diagnosis, which will translate into lung cancer deaths in Appalachia. That's fewer Kentucky families facing lung cancer mortality. Now, your lung cancer team has already recognized and is actively engaged in really figuring out what is it going to take to leverage the lung cancer screening platform more effectively in Nevada. And they published this lung cancer screening toolkit that's available on the coalition website for download. And there's lots of insightful information in there, including an introduction, data to make the case for screening. Perhaps your hospital system needs to needs some more persuading to make this investment in developing a lung cancer screening program, but it also gets into the weeds of who is eligible, how to do the radiology right, what's the magic of the lung cancer screening registry. Although participating in the registry is no longer required for CMS coverage, it is mandated as part of being an American College of Radiology site or a high quality site. How to go about the billing for this, what are the codes, how to build in robust patient follow-up, and how to promote screening and do outreach in our communities, and what can be done. And they also included an attachment that has some clinical resources for some of the things that make lung cancer screening operational. Next, I want to mention that, you know, I've really focused my argument for accelerating lung cancer screening in Nevada based on the data and what is right. That's all carrot to me. That's kind of doing what's right for our community and reducing the burden of lung cancer in Nevada. This is a bit of more of a stick approach that's coming. So the HEDIS quality metric for lung cancer screening, the development was started in 2022, and quite literally, this link right here is the only information that is available about it, because it's been a highly non-transparent process that gives me grief. But we know that they've told us that they're still on target to announce their findings and what the lung quality metric will look like. Now, to track and evaluate implementation of lung cancer screening on a national basis. Now, what will this measure look like? We don't know. Is it going to be about uptake of low dose CT like we do for mammography, other things, or will it really lean into the process of low dose CT and evaluate whether the shared decision-making consultation is being documented, or will it require both? Will it be kind of a combination of things? We don't really know, but if I had to put money on it, the easy way is to document uptake, and that's probably the route that we'll go. And I think that would be unfortunate, but that's opinion, not fact. But what I will say is it is going to be a game changer. And unfortunately, it's a stick approach as opposed to a carrot approach. But hopefully, combining the stick and the carrot, we can get more folks involved with offering lung cancer screening in our clinics across our country. I fully believe that the analogy of a snowball rolling downhill and building up speed is relevant. You know, we are still here. Yeah, I will acknowledge that sometimes we end up patting ourselves on the back in Kentucky because we're all high and mighty with being number two. But frankly, 10% stinks. That means 9 out of 10 people that are eligible for lung cancer screening aren't getting it. That's terrible. That is truly terrible. So really, the best frame is to think about lung cancer screening as a health inequity compared to our implementation of mammography and colorectal and cervical cancer screening. But I also fully believe that if we build more person-centeredness into our lung cancer screening that truly puts the community that we're trying to engage at the center of the process, and we get out of our offices and our hospitals to get out in the community to start normalizing this, to communicate to the community with empathy, to share our optimism that we can help improve outcomes, and a sense that the time is now. This is our best opportunity to do this, and that we can get to where a higher percentage and a dramatically higher percentage of our community are getting the benefit of participating in lung cancer screening. So I'll close with saying that this tool has promise like nobody's business in terms of what we can potentially do to change lung cancer in Nevada and across our country. But the challenge is implementation. And if we want to turn that implementation into an opportunity, we need to focus on equitable, optimal strategies, packing in person-centeredness and community engagement. I've said it 7 times already. We're getting the technology part mostly right. The thing that we're missing is the people part. And if we really want to do this, and I really feel like Nevada is poised to accelerate lung cancer screening and really glean the benefits for the citizens of Nevada. And this is a huge opportunity to actually change outcomes in Nevada. And so I'll stop there and turn it back over to Lily. And thank you so much for the opportunity to kind of share some of my thoughts and backgrounds on lung cancer screening.
Thank you. A lot of amazing information in there. I did offer in the chat if anybody would like a hard copy of the toolkit, we are more than happy to send it out. I see some people already asking, so please just send your addresses. And are there any additional questions?
Lily, it doesn't look like we have any questions in the Q&A or the chat. And we don't have any hands raised, but we'll give everybody just a sec if there's a question that they want to ask.
I'd truly love to have some questions or feedback or thoughts about how you're implementing lung cancer screening in your communities or across Nevada, or things that you think need to be improved or changed, or areas where you disagree with me, because I sometimes purposely say things a little bit extreme to try to get a reaction about it, but in reality, I think you probably understand that I think what we're getting wrong is not understanding our community effectively, and not empathizing with them as for having a long history of smoking and other tobacco use, and how our healthcare system has treated them in ways that has not engendered a lot of trust, and that we have to be trustworthy if we're going to leverage this platform effectively. And we're new at that.
I think perhaps people will digest the information, and if you have follow-up questions, please feel free to send them to myself. I'm putting mine in the chat now, and we can follow up. And here's to hoping that Nevada will also be able to do a road tour soon. Well, we're doing a mini road tour soon, so look for the toolkits and resources coming to one of your communities.
And Lily, we did get a question in.
Oh, perfect.
So we have a question here. Is Dr. Stutes recommending that we separate our quitline promotion from our lung screening promotion?
So no, I wouldn't necessarily recommend that, with the caveat, it depends on how you're doing it. It depends on the wording that's being used and the imagery that's being used in some of those promotions. Because I think we can make those things together. As a matter of fact, that's one of the reasons why we include um, our in our quality system, we encourage folks to include counseling on radon, and if they don't do counseling on radon, we encourage them to include a pamphlet or something about radon, because we want to extend the notion that we're not there because they smoke. We're there because we don't want them to die or get lung cancer. And when we do things like talk about radon, that is a risk factor for lung cancer, when we talk about secondhand smoke, we're communicating that we don't just care about them because of their smoking history. And we feel that that's destigmatizing the platform. And so while we don't advertise our screening programs as lung cancer control programs, because people don't understand what lung cancer control is, that we still advertise them as screening programs, but we embed the principles of lung cancer prevention or risk reduction and control into the programs, so we can have the greatest amount of impact and build relationships. When we communicate more to people and spend more time with them, we build a trust. We're more likely to build a trusting relationships, and this is where we think where high quality participant navigation, whether it's a nurse navigator or a lane navigator, in the mix to establish those relationships, becomes a vital part of really I've used the term a million times, leveraging the lung cancer screening platform. And I didn't emphasize it here, but our federal government spent $250 million to support the National Lung Screening Trial. That is way too much of a public investment to let that sit on the sidelines and be some kind of academic scientific exercise to gain knowledge. we have to put that to use for the people who paid for it, and those people are us.
Thank you, Dr. Stutz. I see another question in the chat from Justin. Is there any funding currently in place to improve staffing for scanning projects? That's one of our biggest challenges in Northern Nevada. There's not to my knowledge, but perhaps any to your knowledge?
So, you know, the reimbursement rates for screening change all the time. You know, on an annual basis. I'm not an expert in the financial side of this, but um, unfortunately, currently, the new legislation to support billing for navigation, I believe, is restricted to survivorship navigation, meaning post-diagnosis, and therefore pre-diagnosis navigation is not yet reimbursable. We want to go in that direction, but I think there's a huge return on investment here, because, and I'll make the argument. So Vanderbilt University was struggling with implementing their lung cancer screening program with about a 23, 24, 25% adherence rate. As soon as they added navigation into mix, within the next year, it achieved 50%, 57% adherence. So what you can say is that that's a doubling of the people that are coming back based on that investment in a navigator. Now, there are financial models out there on the National Lung Cancer Roundtable website, as well as the Go-To for Lung Cancer website, that allows you to put in the statistics about your program, and then you can say, what if I added a navigator at $80,000 a year or $45,000 a year? How is that going to impact the economics of my program? The other thing that I use is a Shark Tank analogy. Whenever someone is pitching a new subscription service or a new app or something, Mark Cuban always asks them, what is your participant acquisition cost? And they say, we have to spend $100 to get one person to use our app. And then they say, what is your retention cost? To keep people involved, we spend $22. Aha, aha. If you invest in adherence, which is the right thing to do for patient outcomes, it's also the right thing to do for the economics of the program, because you're spending less to gain more. It's easier to keep people coming back than it is to get them to help them to start. To finding someone new to start is a lot harder than keeping them engaged once they've already started. So, and that's navigation in a nutshell. Investing some to have a higher return on that outcome. So that's my argument for investing in, and I realize you'd have to actually go through the calculations in one of those economic models to see that. But I encourage you to play around with those models. Have you seen hospital systems piggyback onto other hospital systems to refer to a low-dose CT program? Absolutely. When we embed high-quality smoking assessments and have a very good, robust lung cancer screening eligibility platform, we can use our electronic health records to either ping our primary care clinicians. We know they hate that. You know that those reminders become the bane of the existence, but we can also send flyers out to targeted individuals to let them know about our program, to use empathic communications. There are some team members, the University of Utah has developed some tools to really help leverage electronic health records to send out. We've also seen programs at Vanderbilt, and we're developing one here in Colorado to leverage the mammography platform. If a woman is already buying into the notion of cancer screening by participating in a mammography program, why don't we ask them a few questions about their lung cancer screening eligibility to see if we can't help them find a lung cancer screening program too? Because they're already interested in cancer screening. So we don't have to do that. And so the thing that doesn't feel good about that is that's not necessarily an equitable strategy. But at this point, we're striving to get this to as many folks as we can. And so it's a reasonable strategy to bring this opportunity to women who may not otherwise learn about it. And we published a paper showing that mammography programs are generally willing to do some of these things, to have simple wins. You know, they're less likely to make an actual referral and do everything that needs to because of the being resource strapped, but they are willing to do the assessment and hand out a pamphlet or to give people a recommendation or things like that. Um, so so there are places to leverage that opportunity more effectively to raise awareness in other places. Yes, it's the Pink and Pearl work that's being led by Kim Sandler, at but it gets into the clinical operations. It's just not a campaign necessarily like a media campaign. It really gets into the Kim Sandler. Dr. Sandler is a radiologist who has worked in mammography and lung cancer screening, and so it makes it easier to control both of those things when you're calling the clinical shots and dictating exactly what to do. But other programs and other facilities can be doing this to help populate their screening programs.
Right. I believe that is the time that we have today, but we look forward to receiving any additional questions and forwarding those on and getting them answered and working with all of you who attended today. So thank you again so much for your time. And this will be made available on the NCC YouTube series for you to go back and review or pass on to colleagues. Thank you so much, Dr. Stutes. This was awesome.
Thanks, Lily. Appreciate the opportunity.